the mic again, close to you.
Okay, that shouldn't be a problem. From overdose reversal to recovery. When someone overdoses, EMTs give naloxone, and it works. Within moments, this patient who was ostensibly dead moments before is now alert, oriented, sober, and breathing under their own power. But what happens next is the part that most people never see. Within minutes, this person can go into severe and predictable withdrawal. Imagine extreme shaking, vomiting, tachycardia, and intense cravings. And to escape this, many people struggling with addiction will use heroin again or use opioids again within hours. And last summer, I worked on a project that was trying to change that moment. Good morning, my name is Kevin Ochall. I'm a student here. I'm a senior at the University of Baltimore, finishing my degree in policy, politics, and international affairs. I'm also an early entry student across the street at the School of Law. And I'm here today to take a break from studying for finals to talk to you about a project I worked with last summer through the university's Next Gen Leadership Program with Baltimore City Councilman Mark Conway. When I began applying for internships with the college, I was approached by Councilman Conway's chief of staff, who was interested in having me as an intern based on some of my resume. In addition to being a full-time student, I'm also a captain in the fire department. And in my 17 years as a career firefighter, the scenario I opened with today is one that we see all too often. So during my interview with the councilman and his team, one of my roles they were hoping I could fill would be to bridge the gap between his policy initiatives from City Hall to the fire department. The idea he was working on was simple. It was, what if when we encountered an overdose and administered naloxone, what if EMS could also deliver buprenorphine in that same moment? Buprenorphine is a medication that reduces withdrawal symptoms and cravings. So instead of sending someone back into immediate distress, it helps stabilize them in those critical first hours after an overdose. So the goal wasn't just to save someone in that moment, but to increase their recovery profile and to reduce their chance of using again in the next 24 to 48 hours. Heroin and fentanyl are both potent opioid agonists. That means that when opioids enter the system, these drugs are pulled like magnets to the mu receptors in the brain. And these receptors, or the opioids, then bind to these receptors, activating them, which creates this analgesic effect on the central nervous system. In turn, this also suppresses the respiratory drive. It suppresses the gastric tract and the circulatory system. Now, naloxone is an antagonist. It strongly binds to the same reactors I just mentioned. However, instead of activating them, it blocks them. Because naloxone has such a high binding power, it kind of bullies the opioids out of the way, taking their place on top of this the receptor, which is what reverses that life-threatening respiratory distress I just mentioned. But the problem is that the mu receptors don't just control breathing. They also impact our nervous system, our digestion, our heart rate, mood, pain management. So for patients who have developed a physical dependence on opioids, this immediate removal from the body can throw the body into a sudden and acute withdrawal. And this is where buprenorphine comes in. Bup has an even stronger binding potential than naloxone. So when it's administered secondly as a sister medication, the bup then binds to the brain receptors and occupies them. But unlike naloxone, bup is a partial agonist, similar to opioids. So it partially activates the receptors, but without creating that same high that heroin or fentanyl would cause. Additionally, bup has a long half-life, meaning that it sticks around for as long as 24 to 48 hours. And the idea is that if we can leave this patient who had just had an overdose in a relative state of comfort, they're going to be much less likely to use again in the next couple hours. And also we're hoping to create a level of trust between the patient and the provider, that they can trust in the system, that they're going to be more comfortable the next morning, reaching out to follow up with treatment plans, talk to doctors, talk to therapists, and ultimately move them towards recovery. So my role with the city council was to see if this idea could work, not just in theory, but here in Baltimore City. I started by talking to people in the field. I spoke with EMS providers in Baltimore and in my own department, trying to understand first how familiar they already were with buprenorphine and what hesitations they might have with administering it in the field. I had met with EMS leadership here in Baltimore City, had a candid conversation with the chief about what he would and would not be comfortable with rolling out in a pilot program. There is no such similar pilot program in the state of Maryland. So getting his buy-in was very important because even what looks like a good policy is not going to succeed if there's not trust in the leadership in implementing it. And then I looked outward. I looked towards primarily the West Coast, where this doctrine is much more established, and then to more analogous cities like Pittsburgh and Camden, New Jersey, which have had success with similar implementation. I spoke with substance abuse professionals to better understand what happens after the ambulance leaves and where we're failing these patients between the immediate life-saving action and their ultimate recovery. But the biggest issue I found was not medical, it was legal. And what I found was that when I reviewed the bill that had been submitted prior to my arrival, it was too broad. It was asking EMTs to administer medication they weren't authorized to give, they weren't trained to give. Even for the more highly trained paramedics, this bill still exceeded their scope under regulation. So that's where my background helped. I was able to spot these gaps and rewrite some of this policy, make some amendments that brought it more into line with current policy in the state of Maryland. So instead of pushing forward with a bill that couldn't work, the focus shifted. We went to MIMS, which is the Emergency Maryland Institute for Emergency Medical System Services, and kind of worked with them to get some of the language changed in the protocol that would allow this pilot program to happen. And this is a slow process. It normally takes between 12 and 18 months. It requires doctors, research, data, buy-in from providers and sponsoring agencies. But we were able to create just enough wiggle room in the protocol to allow for our pilot program to kind of take seed. And on July 1st, after about only 2 months, they released their updated protocol statewide, which included our proposed changes, which gave us, again, just a little bit of room. And with some negotiation, we got buy-in from Baltimore City to implement the pilot program. And what this project showed me is that good policy is not just about having the right idea, it's about making the right idea work in the real world. In this case, it meant aligning 3 things: public health goals, legal authority, and the realities of emergency medicine. And sometimes the most important contribution isn't proposing something new, it's just identifying why something won't work yet and how we can make it work in the future. Because in this opioid crisis we're experiencing here in Baltimore, small changes like this can fix the few minutes after an overdose, and they can have a real impact on whether someone survives and whether they recover. Thank you.
You couldn't have timed that better if you tried.
I did try, actually.
Yeah, I know. So actually, I'm going to ask a question this time. First, I'm just going to say thank you. You are the first ever time we've had someone do an internship at this. So delighted that we came up with a way to do that. Dr. Davis was adamant we figure out how to do it. We did it, so I'm glad. That,
it was too fruitful not to talk about.
Yeah.
Great. Yeah.
So my question is, so when I'm asked is to like help students here come up with a place to like find more data or compare things to for Baltimore City, like Philadelphia and Camden are often one of the best choices. And I'm just very curious how, because you didn't have that in the slide, how successful has this been in Camden, if you remember from looking at your comparison?
Well, we're talking about margins, but every margin is important. So I will say significant. There is even some numbers, and these are mostly from the West Coast, that suggest that there's maybe a 25% increase in recovery profile for patients who are receiving buprenorphine either in the ER or in the field.
Ooh.
So to get this into the hands of field providers is very important, mostly because when patients recover from an opioid overdose, they often refuse treatment because they are sober. They do have that right to not go to the hospital. And if we don't have a lot of reach into their lives after we drive away, when the ambulance leaves, and they start feeling bad again, they're not going to want to call us back. They're going to want to take matters in their own hands and find their own solution. So if we can leave them in a position of trust and comfort, they're more likely to follow up the next day or the next 2 days with the provider.
Any other questions in the room here? Oh, Dean Spencer, you are a question machine today, but this is kind of your jam, this one, really. So,
this is very interesting. Obviously, a lot of citizens are allowed to use naloxone in the field, and I got trained a couple of years ago myself. Is there any hope that this, and I'm not going to try to say it, the buprenorphine will also go down that route and sort of a mixed ability to have citizens trained for this?
Whereas it is available in the medication we use called Suboxone. Suboxone is naloxone and buprenorphine. However, it's unlikely you're going to see this administered by a civilian because buprenorphine is an opioid. It's a controlled substance, it's a narcotic. That's why EMTs can't give it, even paramedics. It has to be regulated carefully through the state and through training.
Great. Okay, thanks.
Anyone else? Oh, one last one, and then we're gonna.
This is a great presentation. Idealistically, would this take some sort of collaboration or connection with, say, like an outreach program or with hospitals in order to kind of streamline the patient to going directly into some sort of
Absolutely.
plan?
So again, on the West Coast, this model is very heavily used in the ER system. Even in Baltimore, we do have mobile clinics that post up around the city on certain days of the week that distribute buprenorphine with doctors on site. The issue now is just increasing this immediate aftermath of the opioid reversal to make sure that this person is comfortable and able to receive more care the next day. That's our main goal here. To not leave them in that crushing withdrawal state as we pull away.
All right, one more round of applause for Kevin, our first ever internship person.